I'm Amanda Ross. I own Patient-Centered Solutions. I am a consulting firm that specializes in PCMH consulting and EMR optimization. I see some of my clients in here, so it's good to see you all. And today we're going to be going over high-level items related to a patient-centered medical home, more so the concept of care, and then sprinkling in a little bit about the NCQA requirements if you are an NCQA PCMH. Before we hop in, can you raise your hands if you are currently an NCQA PCMH? Awesome. Anyone who's thinking about it? Okay, awesome. So this session is more geared towards if you are already a PCMH. However, this will give you a good dive into what to expect if you are starting from scratch. All right, All right, so today what we're going to talk to you about is navigating PCC tools for a patient-centered medical home. And this is more so the concept of care of being a patient-centered medical home, what you should be doing to keep your patients within your four walls as much as possible. And then we will add in items that are related to the NCQA PCMH reporting requirements for 2026. We're going to talk about how we implement best practices and scale them up for larger practices, and then daily tasks for your staff to incorporate patient-centered medical home concepts. So what does all of that mean? Basically, we are going to teach you how to optimize your EMR to move through your day easily. This is going to be related to the huddle sheet for pre-visit prep, how to build reports and report library, how to review documentation quickly to make sure that it meets the requirements and that someone coming behind you would be able to understand what you're trying to say about that patient. Okay, so PCMH points. These points are not necessarily related to a concept of care of a patient-centered medical home. So when I say a concept of care, that's keeping your patients within your four walls, and it's how you want to operate. Then there's the incentive program for patient-centered medical home, which is tied to the NCQA. So a lot of this is tied to NCQA. Document everything. That means basically every patient engagement you should be documenting. And there's obviously a few things that you're not going to document. They're calling in for an appointment. We're not documenting that. That's just scheduling an appointment. But more so, this is around they're calling in for clinical advice. We should be able to see those phone messages that are in the system. They're calling in because they're having issues coordinating a referral. That should be in the system as well, not in your paper binders. They need a prescription refill and they've got a bunch of questions about the prescription. The questions should be in there because our goal is to hand off your charts to NCQA, the National Committee for Quality Assurance, and for them to understand what you're saying. Now, we're all in the business and you hand me a chart and you go, but I talked to that mom, I told her the results. I know I did because that's just what I do. I can't prove that. NCQA is going to go, great, but it's not written down. So document everything because what's the rule of thumb? If you don't document it, it didn't happen. Follow your deadlines for NCQA and for your payers. I cannot stress this enough. There are changes at NCQA, and if you do not follow your deadlines, you could potentially lose your recognition. If you lose your recognition, you could lose your incentives. If you are in a state where you get a lot of incentive money, like Alabama, Florida, New York State, pay very, very close attention to those deadlines for NCQA. So what that means is your annual reporting date is 30 days ahead of your actual anniversary date. Do not be submitting on your anniversary date. Do not be submitting on August 1st, submit on July 1st. Makes a huge difference. Your deadlines and your dates for payers. So what I mean by that is find out from your payers when they are getting their transmitted files from NCQA for your incentives. So for example, in some states, the files are transmitted from NCQA to the state on the 5th of the month. If you're not in there by the 5th of the month, you could potentially lose your incentive for the next month until they pull again. If anybody's ever lost incentive dollars or had issues with billing, you know how challenging it is to then go back and get that money. It's very, very hard, and NCQA takes a very hands-off approach to it. They go, we're so sorry for the inconvenience, but for you all, that's a lot of money. Remove PHI for NCQA. This is another big one. If you do not remove the PHI, they automatically kick it out in their system called QPass. And then when you are on the phone with them or you were doing your submission for annual reporting, they go, we didn't get that, we didn't see that. And then what happens if you don't have that piece of documentation anymore, or you spent a ton of time on that? It's no longer there. So just be very mindful of PHI. Reference the standards. So what I mean by that is when you are submitting documentation to NCQA, you need to assume that they do not understand your documentation at all. The individual that's reviewing your project does not have pediatric experience, and most likely they have never worked in an office, meaning even in adult care. So you are going to want to over-document your documentation. If you have a chart note that's going across and it's about clinical advice, you're going to want to highlight exactly where the clinical advice is, and you're going to want to say this is AC05 clinical advice. Right there, smack dab. Use Adobe, it's the easiest thing, use highlighting. You also want to use the comment boxes in QPass to explain your documentation and why it meets the standards. So if your interpretation of the standards is that this child is meeting it due to complexity of one chronic condition and they have a medication that you're managing in-house, and so that's your care management patient, explain that. Over explain everything. We always want to say less is more is more here. More is more, they'll throw out what they don't need. Prepare for the audits. So this is directly related to those of you that are already a PCMH. They have these lovely things called audits. So when you submit your PCMH project, your annual reporting PCMH project, you could get hit with an audit. NCQA says it happens about 5% of the time. Personally, I think it happens about 20% of the time. That's just my feelings with how many of my clients get audited. And what happens is you hit submit, and then all of a sudden your project gets put on pause. It says you have been hit with an audit notification, and you have 7 to 10 days to turn the project around. The audit project is a completely different project than your annual reporting project. So you'll have your annual reporting items, and then you would have an audit project that is put on top. And it is quite stressful to try to do that in 7 to 10 days. Now, if you are not working with somebody who has direct experience with NCQA, you're going to have no idea what the audit items are. It's not widely known. You cannot contact NCQA and go, hey, what are those audit items? You're going to just hope that maybe one of your friends tells you if they were audited, or you're going to want to reach out for help. Okay. And again, understand the individual reviewing has no experience. I cannot stress this enough. I have clients that go, but they should understand, they should know, they're the ones that are reviewing us. They do not. So for example, ADHD, I have had a reviewer go, what is that? Yes, what is that? And when we said that they are supposed to come in every 3 months, they go, why? Now, all of you all know that. You have them come in every 3 months because they need their medications. So that is the level of the individual that you are dealing with. They're lovely people, they do their job, but they're not peds. Okay.
Circling back on the audit point, if you do get flagged for audit, please contact your client advocate at PCC immediately. I have helped folks through this. I know it feels very scary and overwhelming, but they both ended up passing successfully. But the sooner we know that you're in a sticky spot, the sooner we can help you and get data to substantiate whatever it is that NCQA is looking for more examples of.
Yes, good point, because you have 7 to 10 days to turn that around. All right, so your basics of documentation, you're going to want to use your structured data fields, and this is going to be very specific to your problem list and to your medication list and medication reconciliation. Do not use reminders or medical summary for these items. I have clients that go, but I put it in the chart, it's free texted. Great, that works, I love it, but it's not going to populate a report, okay? So problem list and medication reconciliation are a part of PCMH 2026. If you're not doing those steps correctly, we're going to go into that in just a moment on how to correctly do that. Social determinants of health. This is a really big item to NCQA. While they don't make it mandatory for annual reporting, They love to ask about it, and it is nice to just know and have off the tip of your tongue. So if you're not sure what is relevant in your population as far as the social determinants of health, assess. Educate yourself also on social determinants of health, because most folks are not aware that family dysfunction, discord, divorced parents is social determinants of health. So if you're in a practice where you have a lower Medicaid population and you don't have folks that have issues with lack of resources or transportation, which are usually go-tos for social determinants, kind of step outside of that and look at the family dynamic. That's a good one to use. If you're not sure where to put something, so again, over documenting, try to limit where you're documenting where there's no timestamp, like mark as reviewed or something that's going to automatically pop a timestamp in there. Use a phone message. Use a phone message because it's going to record who did it and at what time, and it's going to be in your visit history section.
Absolutely.
Visit history. So that will be there. It doesn't matter what it is, just put it down somewhere. Now, and documentation points. So again, more. Go with more. There is a huge difference between go to the ED for further evaluation and then what I have listed out here. This is an item that is a part of Annual Reporting 2026 and a new PCMH. So if those of you that are new, take a look at this right here. This is care coordination with hospitals. And so we have to prove to NCQA that we are communicating with the hospitals during the initiation. And I'll get chart notes and it says go to ED for further evaluation or advise patient. And I'm like, no, that does not tell me that there was communication. So you're going to want to be very detailed. This is just an example called one-stop transfer line. You could do something along the lines of printed clinical summary and sent with EMS, or printed clinical summary and gave to parents, faxed records over. However you are communicating with the hospital, make sure you're jotting that down. This is something that can go in your plan for the day or in a phone message as well. It doesn't matter. It just needs to be documented.
Yeah, and it helps me, like the framework, the state of mind is, these are not notes from me internally, so go to ED for further evaluation. That's like a quick little note a doctor would jot down. Think about it like the guardian of your patient, the child, needs to read this and understand what the note means.
Yes.
When it's fleshed out and in like real full sentences, that's what NCQA is going to want to see. And circling back to social determinants of health, if you use Chattis, they have a great one called the Hunger Vital Signs. The families like it. It's only 2 questions, and there's so much reporting available to prove how many people you gave that particular screening to and what the scores were. So that's a really easy, low-hanging social determinant of health, the Hunger Vital Sign.
Yeah, good point there with the Chattis. You also have other reports that are available in Chattis, and you can have the Chattis folks pull those data points for you, and you can submit that directly to NCQA. So if you do have Chattis, just keep that in mind that that's really helpful for PCMH. All right, so PCMH 2026 reports. This is new, like new. It was released July 1st, so I'm still a little bit bumpy on it. We have not put anybody through this yet. We have not introduced it to clients because it was just released. We had to review it, and then the first folks will be submitting in January, okay? So problem list report. This seems really basic until you realize that you're not documenting your problem list for the kiddos that have no problems. So what you're going to want to do here is use the Meaningful Use Stage 1 report, or you can use in your PCMH report library the KM06 Predominant Conditions report. And you're looking for at least an 80% have documentation of a problem list. Your predominant conditions is not going to give you a percentage, it's just going to give you a list. But your MU Stage 1 report will give you a threshold of where you're at. And correct me if I'm wrong here with the descriptions of the reports. The denominator is unique patients that have had an appointment, so it's not appointment based, meaning one patient counts one time, and then the numerator is they have an active problem list.
Right, and much like if you're familiar with the pains of the medication list, you're having to prove when the answer is nothing. So absence of data is not positive in the numerator. You actually have to, and we'll demonstrate this, diagnose them in the problem list as no known problems. Just like you have to check off patient takes no meds. Absence of data isn't a positive. You need to put in the data that they do not take medications, that they do not have a problem list.
Yes.
Or a problem on their problem list. They all have a problem list.
Yes. Yep, you definitely have to do that. Language report. This one should be very, very simple for everyone. There is a PCMH language report in the report library. And then you can use that. If you're a multi-site, keep in mind that your PCMH reports are provider specific. So you are going to possibly want to use a custom-built report out of the report library. I suggest that you contact your client advocate if you are a multi-site practice. And we're going to hop more into the multi-site requirements down the road, but basically NCQA looks at your denominators. So if you have an inflated denominator with language, let's say you have 1,000 patients at one site, but then you submit another measure that should be very encompassing of your entire patient population, and it's 400, NCQA is going to flag that. Okay, so just keep that in mind. Medication reconciliation. This is different than up-to-date medication list. Folks get these two measures confused all the time. So this is medication reconciliation on care transfers. Care transfers are new patients, new babies, or when they have left your practice for other care. They could have gone for a referral or to the hospital for an ED visit. That is
Urgent
a
care center, flu clinic at school, it all counts. They saw
Yes.
another clinical decision maker between the last time they saw you.
Yep, and the easiest way to capture that is during intake, triage. Have you been to any other facilities or seen any other healthcare providers? Go back for me 1 second.
sure.
I think I missed. Okay, medication reconciliation. This is a difference for those of you that are currently recognized. You're used to me screaming out 80% for everything. This is now 90%. So this is going to be a big change for those of you that are currently recognized, but also for those of you that are not doing the medication reconciliation process correctly because you've just been doing medication list. Now go ahead, please. All right, so your medication reconciliation comes from your ARA component in your protocols. You have to check both boxes for this particular measure. Top box is what puts the patient into the denominator, bottom box is what puts the patient into the numerator. I have clients that come to me all the time and tell me, I do this, and they check the bottom box. If you check the bottom box, you are doing nothing at all. It's not tracking in a report. It's literally just living in your encounter. It'll be there. That's great. You'll be able to tell that you reconciled those meds, but it's not going to help your report at all.
And again, people think, it's understandably confusing the language here. You should only be addressing the second box when the first box is checked.
Correct.
You do not need to check off medication reconciliation performed at a routine well visit where you see this kid all year long. It is only when it is a brand new patient or they saw another medical decision maker between the last time they saw you and the date of the encounter you're charting.
Correct.
So if they went to an urgent care
Correct.
Yes.
between their last two well child checks, this is a transition into your care.
Correct.
Yes.
And
Go
reiterating
ahead.
that, so if someone went to urgent care between their 2 well child visits with you, that is a transition of care. You would check the first box and then perform the medication reconciliation and check the second box.
Is it only prescribing clinicians? So like if they went to OT, PT, a lactation nurse, would that be a transition of care or not?
Yes. Technically, when they leave your walls, yes.
Yep, I'm saying if they got a flu shot at a school clinic, something else happened. So just better safe than sorry, that's a transition of care. Lori. Lori asks, what's the denominator in this then? The denominator is all the folks you have marked as the first box.
Care.
Patient has transitioned into my care from another clinical setting. The numerator is, I also check the second box. So I get really firm with my client saying, if you're already checking the first box, there's no reason you shouldn't be able to check the second one. I want to see 100% scores. NCQA wants to see 90%. You're already bothering to check the first box. Check the second.
Yes.
Where people, the pitfall is they don't even have it in their protocol. So I'm going to demonstrate actually how easy it is to add.
Yeah, go ahead while I'm going to chit chat about problem list.
Beautiful.
Was there another question? Good, very good point. So this is a metric where they're not going to look. Does the denominator of the medication reconciliation measure matter if it is small, right? That's about where we're at? Okay.
Yeah.
So technically, there is a minimum reporting denominator of 30 for all measures. However, if you are a small practice and you have a bunch of established patients and you're not taking in new patients, I have seen this measure under 30 and they take it. You just have to explain. There is no you didn't hit 150% or 10% of your patient population. They don't look at it in that manner, and they do not look at this measure compared to other measures. So they're not going to look at the denominator of this measure compared with your language measure, where your language measure is your unique patients, okay? But I do want to call out, there is another measure that is documentation of the medication list. That is a measure where the denominator is unique patients during the reporting period. So that should align with things like your language measure, which is also unique patients, a part of that reporting period. And I think we have a little bit more on the medication list report as well.
Absolutely. So I am in a Train EHR environment, and I'm going to the configuration menu and down to the protocols. This is how do I make sure I've got this magical ARA component that the entire medication reconciliation measure is measured against. So I'm going to go to the protocol builder. I'm going to grab one that I happen to know does not have it, which is my 5 to 6 year well. So here are all my components. I hit add, and I can search using ARA, A-R-R-A, or transition of care. Grab that, add it. I want it where it is right now, but I could scooch my little Lego brick anywhere I want. And I can also double click on that component and make sure that it is an anchor, i.e. on the protocol ribbon to the left while you are charting, there'll be a button to hop to it. So I'm gonna say, yes, I do want to anchor that. Another one, going back to the problem list, we wanna make sure it's here. I believe it already is, right there. And we also want to make sure, I'm kind of skipping ahead a little bit here, that we have care plans. So just while I'm in Protocol Builder, I want to show how easy it is to search for the components you may be missing to help you be set up for success with PCMH. Grab it, add it, put it where I want, double click it, make sure it's an anchor. It's that easy.
A little tip with medication reconciliation, run your meaningful use report. If you have a 0 in your denominator, you might not have the ARA component in your protocols. Some of you might be very familiar with your protocols and you immediately know that you do not, or you do have it in there. But that's just my go-to when I'm taking in a new client, is I go run that meaningful use report, and looking at the denominators tells me a lot about what's going on. All right, your problem list. So we've touched on this already, but this is, again, huge. Just make sure you're documenting in your problem list no known problems, or you're going to run into an issue when you run the report and you're not showing an 80%. Are they going to take away your recognition? No, but our goal is to get them to not ask questions.
So a report that can be run to show those that have nothing on their problem list, so that you can audit yourself and at this. So
That-
Yeah,
Yep.
so someone asked, is there a report where I can audit where my problem list is at right now? There's one wonderful magical report that tackles medication list, medication reconciliation, and problem list. It's Meaningful Use Stage 1.
There we go. All right, so top to bottom, problem list, there's your report.
Thanks for that one.
If you slide over and use the details tab, you will actually see who is not in your numerator. Fifth measure down, medication list. This is going to be where you're documenting an ERX. So what counts here is that you're prescribing a med, or that you are saying there are no active medications. And then second from the bottom, medication reconciliation. This is where we're doing the ARA component in your protocols. With all of these, you can slide over and use the details tab to see who is not in your numerator. A few things that I want to call out here, the requirements. Do not look at these. These are not correct. So this
They're very old.
Yes, this is based on stage 1 requirements. So problem list, you're going to want to go for an 80%, medication list an 80%, med rec a 90%.
Right, so that greater than 50 is 11 years outdated. I would love to see that updated, but just know, go by what NCQA says. But the report has all the data you need. And again, because this confuses so many of my clients, I'm gonna hammer it home. With the ones that end in list, whether it's problem or medication, no data will count against you. So if the child does not take medication, you have to check off the little box in prescription history that says patient takes no meds. If the child has no problems, a blank problem list will count against you. You have to actually add the diagnosis, no known problems. And that was seen on the last slide.
Can you go to, oh no, you don't have ERX.
Yeah, so unfortunately in the training environment that I'm on, understandably, there is no live PCC ERX, but your client advocate is happy to dive into these concepts with you and demonstrate the workflow to make sure that all your staff is on the same page. And let this roll downhill. The person doing intake should be the one asking the questions about medications and problems and checking off that first ARA box for you and checking off that patient takes no meds box for you before you even enter the exam room. Dr. Lori. That is correct.
Yes.
So say within the reporting period, there's a child that's not on daily medication or consistent medication, but then they get otitis media bilateral, you put them on amoxicillin for 10 days. By the time you then run the meaningful use report, they'll be showing up as a no in the numerator because that patient takes no meds box needs to be checked again. But that's why I love these details hyperlinks. I call them my rainy day lists. You click on that list, you look at all those no's and you fix it. You can go back retroactively and improve your score.
Not for MedRec though.
Yes, I confirmed with Tim this morning.
Oh, you did?
Mhm.
So, okay.
You can go up and clean up after yourself. It's not a fun project,
No, it is
but
not.
it really trains folks to remember those part of intake.
Yes. So can you go over that with MedRec? If they don't have it configured, they realize that it's not configured?
Sure. So this one takes a little bit more of jiggling the handle, but let's say you find out, oh my gosh, we never had the ARA component. What are we going to do? Step 1, add it to every single protocol you use. Step 2, run this report. Find all your no children. You go back to that visit that's in the reporting period that counted as their no.
Well, technically, there won't be anybody because they wouldn't have checked it.
Right.
So they'll have to.
Oh, right.
So what you'll have to do, let's say
It's a
you're.
little more complicated with MedRec.
But this happens all the time. That's why I think it's important that we stop and talk about it, because you have no data and you are about to report for NCQA. You need data. Go back in your schedule and identify who your newborns are and who your quick care transfers are. So if you have an appointment type for hospital follow-up, solid, that's a care transfer. And then go in there and make those changes and just get it over like the 30 mark.
Right, so anything you could do a report on all your new patient build
Yes.
codes. That's your rainy day list. You can do all your ADHD med checks that you know go to see a psychiatrist. That's a good rainy day list.
Yep.
So yeah, it's a little more complicated to boost your medication reconciliation score, but it is possible. It's just not as easy as like checking a box.
I would do this project versus trying to explain to NCQA that you were not doing it and ask for grace. I would not do that.
Yeah, clean up after yourself. It'll build better habits in the future.
Yes. All right, now hopping into care management. So care management, we're going to talk about kind of high level. So with all of your complex patients as a concept of a patient-centered medical home, and then the requirements. Now, those of you that are in PCMH, do not shoot the messenger. I'm talking to you. Do not shoot the messenger with the changes. We will make it work, okay? All right, next slide, please. Care management terminology. It is important to level set on care management terminology, because what you think is care management, I guarantee you NCQA does not. A lot of folks think that care coordination is care management, and that is not the case. So care management overall are your activities to improve your patient outcomes. This is where you're identifying your most complex patients, and then you're putting a plan into place. That plan can also include care coordination for your patients, but care coordination alone is not care management. Care coordination is the coordination between facilities outside of your practice. And then a care plan. This is huge. This is individualized instructions to help the patient accomplish their treatment goals. And the whole purpose here is to help the parent and the child advocate for their own health and basically accountability. A care plan is not your plan section of your note. It is not your treatment plan. There is a huge difference between your treatment plan and patient goals, and we'll hop into that. But NCQA recognizes these 3 terms exactly as we've laid out on the screen. All right, care management criteria. So overall, if you are not pursuing NCQA PCMH, you can pretty much deem any type of patient complex. If you have a patient that's a newly diagnosed ADHD and you find that to be complex, even though the parents are on board and they show up every 3 months, have at it. You can absolutely do that, okay? Same thing with maybe an infant that has 1 bout of constipation. You can call it whatever you want. If you are doing NCQA PCMH, you need to stick to the left-hand side. These are the yeses, these are the nos, okay? So basically what you're going for are complex conditions that you are managing in-house yourself. You're prescribing the medication, you're doing the care coordination, you're doing the forms, they're coming to you. You're going to want to avoid those kiddos that are going to psychiatry or neurology for their ADHD meds, the kiddos that have a ton of different pediatric subspecialists and they're coming to you for their preventive exam and just sick visits, because you're actually not managing their care. You're not prescribing the meds, you're not doing that, that management. One-time conditions. Back in the day, these last few over here, we used these as care management. One-time constipation, earaches, and acute illnesses. That was really big back in COVID when we used COVID as care management. You cannot do that anymore. So steer clear of all of that. Normal typical things like acne and eczema can go on both sides. So you're going to want to make sure it's chronic. It's continuing to happen with the kid. The kiddo is getting eczema flared up, it's cracking, it's breaking, bleeding, all of that stuff. They are constantly having constipation that you can't get to the bottom of.
Right, you have to send them to an allergist or a nutritionist or,
Yep.
behavioral therapy
Yep,
in
well-
relation to the constipation, whatever it may be. It has to be chronic and
Yeah,
severe.
you can't, it is not resolved in one time. Again, though, if you are referring them out for multiple things and the GI takes over the care, you're gonna kind of pull back on that. Question? Autism, yes. Yes. So autism is one where we always review, just go back for me one more.
So sorry.
So autism is one where we always review the chart notes because there's a line with it, right? You have to go to the developmental pediatrician. You're going to start your orders for OT, speech therapy, all of that. And that's a lot of care coordination. However, autism is a care plan that NCQA likes because there's a lot of personal goals with it. There are family goals that are associated with it. So just be very specific about that. A lot of things that I see with autism are around potty training and impulsive behaviors. So as long as you're calling out those specifics, it works out really well. But again, you're going to have to be detailed.
Yes or no?
Yes.
We're going on our 5th year.
Okay.
We've had the same care management for 4 years now. Do they look for change or do they accept, can we just continue the same?
Very good question.
Let me reiterate it. So,
Sorry. Yeah, horrible.
care management, you are seeing some patients for the same complex conditions that you coordinate over several years, 4 or 5 years. Will NCQA allow that same care management that, say, did you create their care plan 4 years ago and it's just continually updated?
Well, it's, for instance, we're doing we created a care management for our Down syndrome kids.
Okay.
We had that.
Example,
We
Down
have
syndrome.
Down syndrome kids, so they're initiated on the same program. And we have old ones that are initiated on,
Yeah.
that are continuing on the same program, so it's a mix.
Yeah, that's perfectly fine. But my question to you is, are you evolving your care plan and your documentation to meet the requirements, or are you using the one that you used in year 1?
We're currently using the one we used in year 1.
Yeah.
So that is going to need some updating, yes.
Yeah.
Absolutely.
You can't use something that was created in 2022 for a testing 2025 or 2026.
I think
They're
she-
going to want to see a new.
No, she means
Using
her.
the same paradigm.
Yeah.
But
Oh.
of course, each patient's care plan
Yes.
is the same.
Her,
Oh,
her
wonderful.
template, her template of the
Okay.
care plan is on the older end. So you're definitely going to want to update that. So the next 2 slides are going to be for you.
Dr. Liza.
I was just going to add to what she was saying is make sure that you're going in at least annually, or probably even more than that. You're probably seeing it whatever 3 months, every 6 months. It's just
So we're going to talk about that as well because there's changes to that. So we're gonna chat about that. Sorry, I want to go back.
Oh, I'm so sorry.
This one. Okay.
You're staying red.
Families with social determinants of health and high cost situations, use these as layers. So you do have to report on 3 categories of care management. Your options are going to be behavioral health, high cost, high utilization, complex social determinants of health. So it's really difficult in pediatrics to write care plans that are solely based on social determinants of health or high cost utilization. So we use these as layers. And what that means is you have an asthma patient and they continue to go to the emergency department at 8 o'clock at night for care instead of into your office. Use that as a mixture of social determinants of health because it's a single mom and she works evenings and she can only get to the ED or urgent care at that time. So make sure that you're evaluating your patients for those concerns. If you only have a few, that's okay. Not every single care plan needs to have social determinants of health or high cost, high utilization. When it comes to reporting to NCQA, the breakup does not matter. So you do have to have at least 30 kids per site that are deemed care management. If you have 25 behavioral, 3 complex, and 2 social determinants of health, you're perfectly fine. The makeup does not matter. Just make sure that you have at least 1 child in those categories, okay? All right. Now you can change. Sorry.
Now we're blue. All right.
All right, non-negotiables of care plans. On the left-hand side, this is where we are now at with care plans. This is what needs to be submitted for 2026. So within your care plan, you are supposed to have a problem list, an expected outcome, patient goals, medication list, management, and schedule to review. Now, there are other things that are in between there that are the nice to haves. If you're my client, I make you put them on there because it just makes my life easier down the road when we submit. What is new is that problem list and medication list. Those are going to be on your visit history as long as you have configured the printout properly, but also as long as you're documenting the problem list and the medication list correctly. Again, that's why we're really hammering on those 2 items. What they have changed, so we used to have just patient goals. They have now shifted and added in expected outcome. Expected outcome is going to be something like lose 3 pounds by the next office visit. The patient goal is now how you meet the expected outcome. So the patient goal is to incorporate the walking and remove Coke and replace it with water. This is the new thing. Again, we have not submitted anyone under 2026. This will start to happen in January. So once we start to submit projects, we're going to get the kickbacks from NCQA and we're going to understand what they mean here. My suggestion to you is if you are using your care plan feature within PCC, that you are going to want to follow the prompts, not medication list or problem list or medication list, but you are going to want to have actual prompts in there for expected outcome, patient goals, and your schedule to review. Those are your mandatory 3 items that I would have in there. Your nice to haves are going to be your patient barriers and your ways to overcome. Okay? Again, this expected outcome, I think, is just them trying to formalize. In my personal opinion, I feel like a lot of it, expected outcome and patient goals, are kind of the same thing. So if you are struggling with this, I suggest you reach out to your client advocate, look at this template, throw it past another individual and say, how can I make this into an outcome versus a goal? And then, of course, if you need additional assistance, reach out to someone, a consultant. Yes?
Yeah, so Lori's expressing that the care plan module within PCC could use some updating. We would love your feedback at this session so that I can submit the enhancement requests. One that comes to mind immediately is the ability to task directly from a care plan so that there are visit tasks that are tied directly to an intervention added. But if you have any others, let me have it. Oh, All right, and Lori's also saying, wouldn't it be great if the care plan were structured in such a way to already be outlined like the best practices we're talking today? Yes, that would be fabulous. We've got a goal, which is essentially the title, we've got the actions, and we've got the notes. What you can do is create a snap text with that framework so that you're just filling in the blanks. Dr. Eliza?
Yeah, so the problem is that adding a care plan is incredibly bulky. Yeah, I have snap text and I use them, but it is bulky. It is not user friendly. And I feel like for the last 3 years I've been asking for this to be in a different, like templated in a way that it is user friendly, almost like a protocol is. Like it shouldn't have to be, going in and adding a whole new care plan, or even to edit a care plan. It's just, going down that section is very bulky and not intuitive.
Yeah.
And then that plan kind of appears in the note, but kind of doesn't, and kind of goes to the portal, but it's just not, it's not like a protocol.
No, I want to dive into that, but just to reiterate, Dr. Eliza is saying the user friendliness or intuitive click path and interaction with the care plan does not feel as smooth as, say, the rest of the protocol, some concerns about how it appears in the note, and also concerns about how it appears in the portal. My kid has care plans in the portal, and I think they're pretty awesome, so I would love to hear, like, after this, let's sit down and like go through some care plans and how they appear in the note and how they appear in the portal to see what enhancement requests we can capture, and also make sure that we're on the same page as to like how they look in the portal, how they look in the note, how they attach to the visit summary. Lori?
What group because you're nurse practice section, so how are you recommending you use the action section for the next steps?
Awesome. So Lori expressed she has some snap text already for care plans, but how do we envision this would be beneficial in, say, the goal title area or the notes or the actions? And we will actually demonstrate that.
Yeah. And just a couple of things. So when I am doing care plans for my clients, we use the goals section as the reason for care plan. And the reason we do that is when you run the care plans by date report, it makes for a clean report. On the column for goal, you'll see ADHD care plan, obesity care plan, whatever it is. So you immediately know what that is. We skip over actions because those are the structured data fields that PCC offers, and they usually don't align with the actions that we're trying to do for peds. And then we do our snap text in the next step section. So it might be like a hashtag CP ADHD, and then we drop in our care plan, we edit per the child, and save. If you're doing your entire care plan in goals, it doesn't matter, realistically. It's documented and it's going to appear on the report. It's just, I'm a little OCD and I like clean reports and I like to submit things that are very easy to understand to NCQA, so that's the framework that I personally use with my clients. One thing that I don't think we called out, internal notes. I have folks that put care plans in internal notes and then they run their care plans by date report and go, I did all of these care plans, where are they? They are not
They just
visible.
popped it in the wrong spot.
Yes.
And to reiterate also, when I'm talking to my PCMH clients, I like to tell them, don't think of the goal section as the actual goal. It's the title of the care plan. And also from a user friendliness perspective, it's one of those long, narrow data fields. So if you put in something that's several paragraphs, you're not going to be able to edit or view or read it very easily. Whereas the notes section is a huge text editable field that's much more conducive to writing out a full, robust care plan using snap text or not. So the goal is really the title of the care plan, like obesity management. And the notes section is the full care plan. And I'll again demonstrate and call out, don't put stuff in internal notes that are actually meant for the family and patient, because they can't see that.
Correct. All right, care management changes. Care plans now must be reviewed twice a year. For many, many, many years, it has been annually. This is new. So luckily within PCC, we have the care plan reviewed field, and when we run care plans by date, you will see the care plan created date and then the care plan reviewed date, but that's only offering us 2 dates. Again, All of these requirements are brand new. PCC hasn't had the moment to work through them. I haven't had the time to work through them on all of the little kinks that we're going to have to work out here. But just know that this is a huge change. Also, I don't know how we're going to prove this to NCQA yet. With PCC, you have this clear-cut report, but I have clients that are outside of PCC, and we have to think, how do we do this? Are we going to have to go to an Excel sheet? Are they going to take the report? Are we going to have to prove it on the care plan itself? So with this one, it's a TBD. We're going to get back with you on exactly how we are going to do this, but do know that those care plans that you might have done in 2024 and they are still applicable, go in there and use that care plan, mark as reviewed.
Mark as reviewed, correct.
With that, correct me if I'm wrong here, if there's been a functionality update. You have to do the mark as reviewed through the protocol, through the encounter. You cannot do it through medical summary.
Correct. They're looking for you to have a particular visit with this patient in which you marked the care plan as reviewed. I already set up the big flare about this new requirement, so we will be working on a query to see how we can prove that someone did more than one mark as reviewed during a reporting period. The care plans by date report does not have an additional column yet, but the good news is if you are properly using the care plan mark as reviewed button within the charted protocol encounter note, we have that data. What we need to figure out is how we're going to prove it to NCQA. So each time you click that, we've got a date user timestamp. Because we've had to pull specific reports for offices for various scenarios. So it's in the logs. We've got it. We just have to figure out how we're going to prove it and how NCQA wants to see it.
Yes.
Does it have to be an in-person visit, or
No.
can it be telehealth, or even like an asynchronous virtual, like
Yes.
digital communication?
Yeah,
It
so
can.
yeah.
The rules.
question.
Go.
All right, so the
Sorry.
question was, does the, I reviewed the care plan have to happen in person, or can it be telemedicine or asynchronous audio-visual, whatever it may be? No, it does not need to be in person. Right.
The rule of thumb with the visits, make sure that it is reasonable. Do not do an ADHD care plan when the kiddo is coming in for a sick visit for the stomach bug and we do not see anything addressed about ADHD. Same thing goes for a well visit. If you're doing a well visit and you're not addressing the chronic condition, do not do a care plan on a chronic condition. They are reviewing your actual note and they will kick it back. Where I've really gotten into an argument with them is doing care plans on preventive visits, because at first they were like, well, no, you can't do that. That's not a chronic visit. However, we have described that in pediatrics, you are oftentimes looking into the chronic conditions on your preventive well visit. So as long as you are documenting that, discussed ADHD, you renewed their meds, go ahead and do that. But just make sure that you're not trying to use a visit as a way to meet a care plan when it doesn't align.
Don't just use it like a data point.
Yeah.
Your documentation should reflect the work you did.
Supersize that visit with your billing.
Right.
Yes.
Further justify that you actually
You did it.
diagnosed
Yeah.
Yeah.
and manage that.
Dr.
Yes.
Lori? Do you have to review the care plan on the actual date of the visit where you saw the patient?
So I have a question to you. Review or create? Because you can, okay.
Review.
Yeah.
Yeah, so Lori's expressing, what if I'm being proactive, looking at my week ahead on Monday, looking at my appointments, seeing the ones who have a care plan for ADHD, can I go into that visit and mark the care plan as reviewed as part of my prep?
Yes, you absolutely can do that. You can also go in after the fact. Like if you're going in 2 or 3 days later and you're doing a care plan, you can do that. Where I say no, and why my question back to you, I have folks that will go do a care plan when the patient hasn't been there in 90 days off of that last visit. No go. You cannot do that. You cannot create that or review it, because essentially you're 90 days down the road, the kiddo should be coming in again. So just keep the context around that. Yes.
Can you have your care coordinator do the reviews? Or does it have to be the physician?
Okay, this is NCQA specific. You can have your care coordinator do that as long as they have the privileges to mark everything off. That is perfectly fine. I'm only putting this out there because I don't know if anybody is billing for care management. If you are billing for care management, you need to follow those requirements. You probably cannot have a care coordinator do it. You're going to have a physician or a mid-level do that. So I just want to throw that out there. If you are billing for it, you're actually billing for care management, doing care plans, follow your billing requirements.
Yeah, I have several physicians who have expressed they do not have time to draft up their robust full care plans. They like to write on paper. It is perfectly acceptable to hand that off to someone like a scribe or a referral coordinator or a care coordinator or a front desker for them to enter the care plan. Like literally just get the data in the chart. NCQA doesn't care who put it in the chart, but things can get hairy if you're trying to bill for that time specifically. We want to make sure there's at least a marked as reviewed with the MD's name, date, time stamp. Dr. Eliza?
So I just want to also push for add to what she said about reviewing and actually not the whole part here, because also if you review the medication, so if you get a reviewer that's really like anal, they could actually say, well, it looks like you reviewed this 3 days before your appointment. Did you actually review this medication? So what I do is like I click, even if you're good at time, but they can see it, click review, just click that review again.
Yeah.
Yeah, exactly.
Yeah.
On the day of, so because you're gonna get somebody anal one day that's gonna like be.
I just have a few providers, so I'll go through them.
I want to go back to the virtual visits, telephone visits for follow-up. You can absolutely do that, and you can have your care coordinator, your medical assistant, someone do that. So in your care plan, if you're putting a 6-week telephone check with nurse, perfectly acceptable.
All right, here comes the fun stuff. I'm going to demonstrate a care plan on poor old Johnny Canning. So I have him in for a 6-year well once the computer wakes up. Good morning. No? Bueller? Of course it worked earlier.
Couldn't have a session.
No, there we go. Hey, all right. All right, so he's in for a 6-year PE. Some things I just wanted to quickly demonstrate to reiterate what some of the concepts we reviewed today. The care plan is or should be in the medical summary, and that's great. It's a great place to check in on it. Here it is, you can expand, etc. But what I want to highlight is that it needs to be part of the visit protocol as well, helpful too if it has an anchor. Now, in this funny case, I charted this visit last night. It's from yesterday. And then I demonstrated the protocol best practices today. So the ARA and the care plan component are not currently anchored here, but it is at the bottom of the protocol. So as reviewed. Expected outcome, etc. So we have a goals section, barriers, interventions, and a note of what our plan is for the follow-up and the next visit, all outlined. Do not put stuff in the area for care coordination notes internal use that you want to attest to NCQA or you want the family, guardian, or patient or other provider to see. They will not see that.
I just I just want to plug in here. I have a few practices that are really into care management. They have a lot of complex kids, and they use the care coordination note as a section to tee them up for their next visit. What are they going to check? What are they going to ask the family? Just as a little reminder. So if you are really into this, there's a suggestion, but it is not required. Family does not see that. Exactly, yes.
Right, so there's a very valid use for those internal notes.
Yes.
I just want to make sure you're not putting your public plan that you're intending for the family and patient use in there because they won't see it, but you definitely should be taking some internal notes if they're relevant to your staff and your care plan and your care coordination.
In the reason for that, you could always go use your reminders or your notes in medical summary, but then you're clicking out of that, you're not in that section. This is cohesive, it's very visual for you. And I found it to be pretty helpful because then they go back, they look at that care plan, the kiddo comes back in 3 months, and then on the next care plan, I see where they have said, we asked about grandmothers feeding the child and things like that. So it works out nicely.
Another cool feature of the care plans is this ability to add team members by default in the drop-down. Any personal contact, the patient themselves, and guardian and billing account will be in the drop-down. Obviously, this one isn't very robust. We're in a test environment, but there are times where the patient, probably in adolescence, could be one of their own team members. They're responsible for some of these actionable items to meet the expected outcome and the goals. So wanted to highlight that, but it also pulls in anyone you have in your professional contacts manager. So I'm going to grab Dr. Eatwell. And what's cool about this is hopefully this family has an active portal user and care plans are configured to be active in the patient portal. So not only can they look at all of this at a glance, there's no like piece of paper they're losing, they always have access to their care plan, they can tap on the phone number or email or address on their smartphone from their care plan in the team member section and immediately call those folks. So that functionality is really cool. If you have any questions about Professional Contacts Manager, if you're currently keeping all of your referrals and other providers in, say, like a spreadsheet or a Google Drive, get in touch with your client advocate because we want to bulk update and add those to your EHR so that you can have more robust and functional care plan team members. Do you want me to demonstrate patient visit summary now?
Do you want to do a care plans by date report so they can see how that goes?
Sure. Yeah.
Yeah, I think this is important, especially because we've really hammered on the goal, using that as the title. And we'll run the report for you so you can see how it looks and why we like that setup.
So the care plans by date report is in the PCMH section. I personally prefer to navigate the report library by toggling all reports and searching on keywords. It's just quicker. So you'll see the care plans by date has our cute little logo next to it. It means it's one designed by us out of the can. You can absolutely customize this report, but I'm just going to run it as is. So care plans, all creation dates, we can do it by provider, by the care plan status, by the patient flag. We can even exclude patient flags. It's really cool. And when I generate this, again, pin in, you can customize this and add more columns that are available, but I see at a glance the care plan creation date, the goal, which is a nice clean title, when it was last reviewed, its current status, the patient name and number, birth sex, date of birth.
Do the drop down.
Yeah, primary care provider. Oh, that's what it is.
Yeah.
Hold on. I'm like, what am I missing? The good part.
So what's nice with this report,
When your Wi-Fi is strong, yeah.
when your Wi-Fi is strong, but when you're reporting to NCQA, you can actually use this report as your report, your proof of number of patients, and your content. They like this report.
Absolutely. Okay. For the folks who are streaming, my understanding is that the screen share isn't going exceptionally well. So the report that I used was found in the reports menu in the report library. Its title is Care Plans by Date. It's found in the PCMH section, or you can search by keywords. And what we're demonstrating now is I checked off more of those columns of data set that we have available. So we've got the goal, which is the title, then we have those next step notes, I can even report on my internal notes. Again, the family does not see that when you either print out or use the patient portal to review care plan. And I can even see the team members I've assigned to this care plan.
And you can remove patient information and just leave the PCC ID for reporting.
Yep, take out birth, sex, date of birth, name, just use the PCC number. Also, so hey, Kate, you said I could generate a care plan. What does that look like? This is the patient visit summary. This is configurable in your system. Notice we have all sorts of great demographic information, their vitals, their diagnoses. You can also check off to include the ICD-10s, the very important problem list that NCQA now wants to see with the care plan. Other health information, and here's what the care plan looks like when you generate it as a PDF. You do not have to print this for the family. You can check off as display in portal documents, or you can have the care plan module live in the portal documents, but sometimes they want something like this to bring to another provider. So we've got our goals, our actions, our next steps, and at the time that I generated this, I did not add the team members, so I pre-staged this earlier. Something that is missing here, because we do not have ERX on this training environment, is their current medications, but that would be showing in real life on a live system if you have medications checked off for patient visit summary. So you're meeting all the requirements from NCQA, their problem list, diagnoses, care plan, and their current medications, including if they take no meds or if they have no active problems.
One thing I want to point out here, can you go back and scroll up for me, please? So we've stressed the importance of a follow-up. If this is an actual scheduled appointment, which I do suggest that you schedule appointments at checkout, it's going to be in the upper left-hand corner. Can you go up? Right there, scheduled visits. They love that because we highlight that and it aligns with what's in your care plan. So if it says 30 days and then right there's a scheduled visit in 30 days, it's an A+ to them.
How many care plans do you advise your clients to have like ready on deck, saved in that kind of format to submit to NCQA?
3 to 5. Oh, a very good point, and light bulb went off here. You need to submit 3 different categories of care plans. So back in the day, you could submit all ADHD or 2 ADHD and a depression. That would be considered one bucket. That would be your behavioral bucket. So make sure you're spreading them out among your buckets or categories, whatever you like to call them. Again, those are behavioral, high cost, high utilization, complex, social determinants of health. So typically what we do in PEDS is behavioral, complex, and then we layer on social determinants of health. I find it's a lot easier to do social determinants than high cost, but you may have a ton of high cost kids in your practice. You just have to assess what you need to do. NCQA will kick you back if you submit all care plans in one bucket. All right, any other questions on care management? No? Okay. All right, now we move to
Pre-visit prep.
pre-visit prep.
Yeah,
Do we have?
yeah, she'll come live in a moment.
All right, well, pre-visit prep is a way for you to prep for your day for your pre-scheduled appointments. And the objective here is that everyone is on the same page. We want the provider to go into the room once. We don't want them having to come out and ask, where's this, where's that, what do we have to do here? We find that when everybody is on the same page, it really helps streamline the visit. And we have a lot of ways that we can actually improve the functionality within PCC and do this. New to 2026, this is on the reporting requirements. So if you are in annual reporting, you are going to have to do this. If you are new to PCMH, you would also have to do this. And what they are looking for is proof that you are doing things like pre-visit huddles, chart prep, or structured communication within the patient chart. New to...
Yeah,
You want me to just keep going?
no, I was just trying to find an like alternative to pulling up our slides.
Your laptop doesn't work.
All right, so we're just going to talk. Within PCC, you have got your huddle sheet. Your huddle sheet is derived from your appointment note field. So if you have got a stellar receptionist that's using that appointment note field correctly, you're going to have a really good huddle sheet. We typically tell folks to make sure that they're incorporating details for sick visits. Don't just do sick appointment. Do sore throat and fever. That's going to prompt us, like clinically, we're going to have our standing orders and we're going to go strep test on this kid. Let's do a strep test before the provider comes into the room. So try and use a little bit more detail when it comes to your sick visits. With your preventive visits, you can use snap texts that are based off of age. We've built age appropriate lists. So you can have snap text for a newborn, like .new, and it's going to pull in all of the items that you want for that newborn visit, or .12-year-old, and it's going to have your PHQ-9, your vision screen, and a risk assessment in there. So whatever you like to do for your preventive well visits, think about building that out into a snap text and then utilizing the appointment note field. And we have a great demonstration of that, but we'll get there. What you're going to be reporting on to NCQA, they have now changed the requirements. Perfect. Okay. So, yep, they have now changed the requirements. You have to prove at least twice a week you are doing, you are sharing patient information, care needs, concerns of the day, and other information that is efficient to patient care and practice workflow. So that's going to look like your huddles or your structured communication or your chart prep. Twice a week. They have never had a requirement that you have to prove it. We have always submitted 1 week's worth of data. That was the requirement. And so this is not really a big change to my clients because you should be used to submitting 1 week. However, now you're really going to need to call out the 2 individual days that you are doing this. So my suggestion is if you're using the huddle sheet, you're going to highlight your day, what you're using there.
How many huddle sheets do you suggest a client submitting for NCQA PCMH keeps a track of to attest with?
1 week. But
1 week's worth,
yeah, but
okay.
what they're now calling out is that you have to prove that it has occurred within 2 days of that week. So you're going to have to prove with your huddle sheet, maybe with like signatures, that you actually had that huddle meeting. Again, we haven't submitted anybody under these new requirements. It's not going to happen until January, so when we know exactly what they're looking for there. But your best bet is the huddle sheet. You don't even have to print that, which is nice because everything you put into the appointment note field will populate. However, if you like paper or your medical assistants like to carry around paper, print your huddle sheet out and have folks sign it. That's always a good answer as well.
Yeah. Questions about the huddle sheet?
So we have our nurses do chart prep almost daily in that field. Will there be something in PCC that'll like timestamp it and user stamp it going forward since that's a requirement?
Sorry, so are you using a free text customized component within the charted visit to mark prep?
It is all chart prep.
Where is it at?
She's putting it's like a free text field within the actual encounter note. That's tough because it's, earlier when we were saying, hey, use the structured data fields as designed, that's an awesome thing that works for human beings reading a screen, but I don't know how we would report on how often you're doing that, a percentage. There'd be a lot of manual labor going through every day's appointments, being like, okay, here's our denominator, and these are the things we did, and how would you prove it without sharing too much PHI. So I would say in that case, print the huddle sheet. We have a blank notes column that you can add to the huddle sheet where people can reiterate what they've charted. And I know that feels so backwards. You can't believe Kate's telling you to print something out and write on it. But in this case, that could work.
It could. I think we would also like to explore the documentation a little bit further. I had another client that did that, and what we did is proof. He was a physician, and he would prep his charts around 6 o'clock in the morning, and the visit wasn't until 11 o'clock in the morning, and there was a timestamp somewhere, and I'm not visually seeing it in my head where the timestamp was. It was up at the very top.
Okay, so yeah, we could crack into how your staff is doing it and how we could make that work.
Because then you could prove that it occurred before the visit.
Does the huddle sheet have to have details about what you huddled about, or just the fact that you huddled? So could you, for an instance, pull huddle with your team and any patient that got huddled on because they need care coordination or care management coordination requirements, you just put in the notes huddled, and would that suffice?
I would not submit that. So
What was the question? I'm sorry.
So the question was, do you have to prove what you huddled about or that you just huddled?
Yeah, you're going to have to prove what you huddled about. Do not put just huddled or discussed. They're going to want to see newborn need records from hospital. This child has autism, room them immediately, they get nervous. They're going to want to actually see details on there.
Yeah, and what, in this imaginary world where you can see our screens, there's some really great huddle sheet functionality. Appointment notes could be used in this case, though not like typical of what an appointment note is used for, but it would show up on the huddle sheet. You can also put the patient flags on the huddle sheet. You can put whether or not they have a care plan present on the huddle sheet. That's its own column. NCQA loves to see that. It's also a great quick daily view of your financials. I advise a lot of my clients to pull a morning huddle and an end of day huddle and see the difference between the monies. Like, okay, well at 7 a.m. our goal would be to collect everything outstanding. That would have been $875 before copays. And we only collected $500. What happened? So it's a great go get 'em list. And again, you do not necessarily need to print, scribble, save, but you can if you like paper,
Yes.
and you should do a few signed ones to be able to show NCQA.
So I will tell you what passes right now. If you submit 1 week's worth of documentation and in your appointment note field, you have a majority, so let's call that 75 to 80% of your patients have got something in that appointment note field that is meaningful, they are not going to ask you any questions. So on your sick visits, you've got fever, cough, other family members are sick or whatever it may be, and then on your preventives, you have got something in there, your newborns, you have something on there. Just think of it visually when you can see the huddle sheet. You've got the columns. Try and keep as few blank spaces as possible, and also if you have like one newborn, or you have 5 newborns on your schedule, and 2 of them have really detailed notes, what happened to those 3 newborns that didn't have any notes? That's something that NCQA is going to call out. So just look at your appointment types in that manner. But keep it meaningful, meaning 75 to 80% have something in that field, and they will not ask you any questions at all.
All patients or only patients that are needing care for patient?
Yeah, you should be able
So,
to run
very good question. So
Figure.
repeat the question. So the question was, all patients or those that are care coordination patients? Huddling is all patients, okay? So it is all of your patients that are scheduled pre-scheduled. We kind of draw the line at same day because that's really hard to huddle on, but my point here is PCC functionality, and your receptionist can put in a meaningful appointment note. Fever, sore throat. Dr. Eliza?
So we print our huddle sheet, and that's what we submitted it, but, just for those who can't find anything to put on it, but we do a morning huddle every day, which I think was time on, because it's required for years now. But it's super, super helpful, because also, things that we look at every single patient coming in, but we do it for the follow-up, so like on Monday we huddle for Tuesday, we huddle for Wednesday, that gives you 24 hours to get any with things that like the patients more complex or things in general that we also look at and add to the huddle sheet is like, oh, needs well visit, or sibling missed well visit, or needs asthma reaching, and that just goes on the huddle sheet. That way you really do get everything for each person. It also helps you catch those patients who are overdue on their well visits and asthma visits, or copays, or paperwork for any of those. And it also helps us figure out who is complex care that we need to like pull more documents for the following day, and we just submit that. But my question is, if we don't, we also put it in our appointment notes with the functionality. With all those important comments on it.
Dr. Eliza is asking, with the PCC functionality, will you be able to print the huddle sheet with all appointment note details?
Absolutely.
On the full page, not on individual notes. Like now it doesn't print all the comments.
Sorry, where are you putting said comments?
Appointment notes.
Yes, full appointment note in detail can be put on the huddle sheet and would,
We'll print in parts.
it will, in its entirety. Yep.
And I love your process. Yes. So Dr.
Why don't we
Eliza's
use the
process
rest
is that
of
she
the
preps her charts 24 hours in advance, and she does a lot of complex care coordination, checking for kiddos that have overdue well visits, sibling visits, anybody that needs complex care basically, or overdue balances, and that is a really great process, and NCQA would love it. It has been required for years, and this past year it was part of an audit. It has not been on annual reporting as a full-blown reporting item for several years, but if you are new to PCMH or you were audited, yes, you definitely had to do this. But Dr. Eliza, your process is great. If anybody has questions, I suggest, and she's willing to talk to you about it, she has a really good process. There was another point with pre-visit prep I wanted to mention.
I think one of the things that got folks jazzed up is creating very simple snap text for appointment notes for preventative care or preventive care. Just create snap like .12y.
Yeah.
And for all your 12-year wells, you've got this amazing appointment note with the expected screenings, vaccinations, etc. Reminders to staff.
Yep. All right. Are we? Can we just pause and make sure we didn't miss anything on?
Yeah.
Huddle. Okay, go to the next one. Okay. All right. Team meetings. So team meetings is on PCMH 2026. There are 2 items that are related to team meetings. Our big point here is that you need to document your team meetings with more than just a notepad on what your topics were. They are looking for formal meeting minutes that state who was at the meeting, what your action items were, who's responsible for taking those action items, and when should they be completed. Now that's really formal. You can go a little bit less on that, something along the lines of, hey folks, last flu season we were at a 43%. Next flu season, we want to be at a 45%. What are our lessons learned from last season and how are we going to improve? That's something that they want to see. NCQA wants to see data points. So they want to see data that's related to patient satisfaction surveys, clinical data, and resource data. So let me explain what resource data is, because I think patient satisfaction and clinical is self-explanatory. Resource data is going to be measures like medication reconciliation, medication list, hospital care coordination metrics. So if you've got access to readmission rates or patients that were discharged, if your office has contacted them, that's another resource metric. I believe you can also use no-show data as a resource metric. What we do typically at PCS is we run our surveys once a year, and we have a team meeting that are directly related to your patient satisfaction surveys. And we go over all of the questions and we say, does anybody have any feedback for new questions for next year? We try to pick one measure for improvement. Oftentimes it's very difficult because the clients score very high on the questions. But even if you have 2 patients that did not score you as exceptional, use that as your QI metric. And then you put that actual question into your meeting minutes. So, hey folks, we got a 97% on contacting patients post discharge. Next round we're going for 100%. What can we do? Okay, Jennifer, care coordinator, you are going to call these patients, and that will pass. What will not pass? We discuss patient satisfaction surveys as a line item. Will not pass.
Some cool tips and tricks when it comes, and for those streaming abroad, we are currently on slide 21 if you're looking at the documentation in the Whova app. My understanding is they can't see our slides, so we're discussing. We're good, amazing. Okay, so some helpful tips and tricks. I have a lot of clients that when they have these staff meetings, run either a Google Meet, a Zoom, WebEx, whatever your
Supernorm.
Yeah, Supernorm, whatever it may be. Team meetings like Microsoft Teams, they all now have Scribe AI features. So focus on the goals at hand, really meaningful discussion, and let a robot take all the notes. And then you'll have these amazing notes of everything you discussed already in a format you can submit to NCQA. Also, if you have decided to pick a metric like we need to get our patient satisfaction survey responses up, not your score, but the amount of people who actually respond. Some folks have become more proactive in tackling it day by day or week by week or month by month instead of annually, and you can use any number of appointment-based reports in the report library to broadcast message them, and that can be text, email, or both. It is free to you. PCC pays for those communications. Depending on your population, some people might prefer text, some email. I love a nice quick text. You create a snap text expander. So whoever's in charge of running this, patient satisfaction survey feedback report, that report is already in the report library, built and customized for them. They plug in their little snap text for the text, and it says, thank you so much for visiting PCC Pediatrics. Please take a moment to fill out our survey. Boop, hyperlink, done.
And I'll give you a little tip that I use with my clients. We use JotForm. You can use SurveyMonkey, whatever your preference is.
Google Forms.
Create your survey link, pop it in there, and it's going to go directly to their phone. If you use JotForm, you can actually direct them to Google as well. Disclaimer, you cannot stop a bad review, but if you know that you have happy patients, it usually works out pretty well. Also, with your patient satisfaction surveys, this is just another tip. Make sure that you're doing them in appropriate languages. So for clients that have Spanish speaking, or we even have some that have French speaking, we have the surveys that are translated, and in the upper right hand corner you drop them down and they can pick their translation, because if you're sending the survey to them in English, you're not going to get a response.
Yeah. So any questions about team meeting structure, requirements, patient satisfaction survey strategies?
Okay. All right, so this is going to be your first item that is required to submit for 2026, staff involvement and quality improvement. So like I mentioned, there are 2 team meeting based items that are needing to be submitted. This one is more related to workflows. So this is, what lessons did we learn from our flu clinic last year? How are we going to improve? Okay, I'm going to let you take some screenshots, and then we're going to hop to the next one because I want to pair it all together for you.
Also, the full slide deck is available in the Whova app, and we'll publish it on learn.pcc.com. I know, I love people, they're all taking their little pictures, but we've got you covered.
The next one's going to be QI5, and this is reporting data points with all staff. So this is where NCQA wants to see the actual numbers that are related to one metric related to clinical, one for resource, and one for patient satisfaction surveys. So what we do, instead of having reporting on this item and this item, we do one team meeting where we pull everything together. We pull the data points and then we pull the workflows, because to me it doesn't really make sense to go, hey staff, we were at a 43 on flu, we want to be at a 45, great job. That only meets this, QI5. When you ask for the feedback and you do the actions for improvement, that's the TC item. Can you flop back to that one for me? That's this. So if we put it all on one document, in my mind, it reads better to NCQA, but it actually makes sense to your staff. Here's where we were at, here's how we're going, here's our goal, and here's how we're going to get there. It's a nice flow. You don't have to do it in that way, that's just my way. That's how I do it. But you do have to have proof of 3 data points. You are not going to get around that. So if you need to do 3 different meetings, have at it, or 1 meeting, but they will specifically say, where is your resource measure? Where is your patient satisfaction measure? And if you point and go, well, we discussed patient satisfaction surveys, they're gonna say no. Dr. Lori?
She's asking, is this for recertification or for new PCMH?
Very good question, actually for both. So this is directly related to the recertification, but if you are a new PCMH, you will have to report on both of these items.
A low-hanging fruit too for one of these items, missed visit percentage. We've
Yes.
already got reports on that, so you can pull, like, here's where we were as of this date per the dashboard, and here's where we want to get, and you can prove improvement over time, and like those reports already exist.
Yes.
You know, you don't have to think outside the box or do any manual work. So that's a really low-hanging fruit, easy to report on and improve data point.
Yes, you can. Yes.
Does this have to be an in-person, or can it be, like, we have a quality newsletter that we send out?
Yes, very, very good question. So the question is, does the meeting have to be in person, or can it be a quality newsletter or some other format? It can be. If you are reporting to NCQA, just make sure you have proof of who attended or who it was sent to. So I love emails. We do a lot of emails, email blasts out, and we just basically copy, like take a screenshot of the 2, who it went to, and then I PDF the entire email so we can see the content of it. Dr. Eliza?
So how do you, are you documenting this?
She's asking, how are we documenting all this? That was the earlier suggestion of, say you're doing this in person, book a digital meeting of some kind, fire it up at the beginning of the in-person meeting, and let the robot take your notes. And it's
Yes.
going to capture everything you discussed.
But how can you document this? You can do this on a Word document, you can do it in an Excel spreadsheet. If you really love your paper and you want to scribble it out, have at it, but make sure you're meeting the requirements of who attended, what were your action items, things like that. Now, what I will say, if you do your scribble paper, they're going to ask, how does your staff get it? So just be prepared to possibly scan it and email it to staff. That's an option as well. That is not one that I would promote for my clients, but I'm just giving you suggestions of what I have seen pass.
Any other questions regarding the team meetings?
Okay.
All right, with that, I just wanted to put a little plug here at the end. Tim Proctor will also be diving into this in the clinical oversight reporting course. We are going to be putting some standardized measures into the report library. Currently, you find some of these, or all of these, in the dashboard, and they're kind of frozen in time as of the last time it was updated. And you're like, well, hey, I need to go back to last year. You'll be able to. The screening for depression and follow-up plan, the way that the current dashboard measure looks at it, it's really just based on billing codes. This new standardized measure in the report library will also be looking for the SNOMED diagnosis descriptors of positive versus negative and the follow-up. So you'll be able to prove more of a complete picture of the depression measure using this new reporting.
Can I hop in there and talk about the objective of this real quick?
Sure.
Okay, so standardized measures are required for NCQA. The depression measure that you have on your dashboard is not in the standardized metric, and you should not be using that. So that's why these are golden. Folks were pulling from the clinical quality measure reports, but some of them were outdated and they were missing patients and things like that. But standardized metrics are required. You are most likely not going to get a custom measure request to do the dashboard depression assessment measure. Dr. Lloyd.
So, whoa, what do I have to do to chart properly for this? More information coming as, we will absolutely outline in great detail, like what is going to happen that makes this count. Because as many of you in this room probably know, the weight assessment and counseling for nutrition physical activity has a very specific set of SNOMED that you need to configure before you check that box for it to count. This will be similar. It's going to be looking for some specific sets of diagnoses present on the visit, and maybe a combination of billing data as well. But I'm excited to see Tim dive into this more tomorrow. The childhood immunization status, we were doing it kind of our own way, for lack of better words, and we're bringing it up to the CMS standards. Also revamping the weight assessment and counseling for nutrition, and more coming on the documentation of current medications and medical record. When I say that out loud, that sounds an awful lot like the medication list measure to me. So I'm curious to see how this new report shakes out and if it will suffice for the NCQA medication list, because that's one less thing we have to pull from meaningful use.
Yes.
Yeah.
On that. Yes.
There's a rumor CMS standards may be changing with this current administration.
There's a rumor that CMS standards may be changing due to a current administration.
With immunization requirements specifically.
With immunization requirements specifically. Yeah, you don't say.
So,
Well, as Ross would say, pivot! We'll pivot. We'll figure it out.
Well, I will say that NCQA does respond to some changes, but remember that they are their own organization. They are not a government entity. So if they want to keep childhood immunization status, they can.
Right.
Yes.
Keep immunizing the children, I would
choose
say.
not to follow CMS if CMS has changed.
Yeah.
Yeah.
We'll see.
That's
Well,
it. We're going to put a big red push pin in that one.
Yes.
And we'll cross that bridge if we have to get there, for sure.
There is a quick question in the chat. So the question is, what is the name of your company, please?
Oh, what is the name of Amanda's company, please?
Patient-centered solutions consulting.
Patient-Centered Solutions Consulting, also known as PCS.
Yes.
So have happened in these years that I've been through, because I've done this.
Yes.
And we were reserting February 15th, which means we had to submit by January 15th.
Yes. Oh, you're a fun one.
We asked them for a change, they bumped it by 1 month.
Yeah.
So we don't have to submit data till February 15th now. This is July,
Yeah.
so there's things in this list that we have not done.
Yes.
What's best practice for fixing that?
So the
So how do we reiterate that? You've got a unique attestation date, right, or submission date
Yeah.
that kind of falls right around these brand spanking new requirements. What can their practice do to prepare?
Yeah. So we do this all the time. The beginning of the year ones are fun. I do want to talk to you a little bit more about your care plan situation. My suggestion is jump in now, because right now you are in your actual reporting data time period. 2026, you're going to report on your calendar year 2025 data. So I would be pulling your reports to see where you're sitting for your data. That's first. I'd go ahead and get your patient satisfaction survey done and out of the way and have your team meeting on that. And then your care plans, I would start to pull that list and update them now. There are other items that are a part of the requirements that we did not cover today because we go over all the time. But those items are pretty easy as far as documentation. So I would be pulling them apart now and then going with your data points first. Data points, data points, patient satisfaction, because to me that's a data point, and your care plans, because again, that produces a data point that you're going to need. And then layering your documentation items like the hospital care coordination, you're going to need to prove that. You're also going to have some lab and data processes to cover.
Bless you. You all look so excited too about this.
Yeah.
Circling way back when we were having a few little technical difficulties, and a shameless plug to talk to your client advocate, we're really friendly folks. This is an example of an optimized PCMH huddle sheet. It is so easy to customize this. Note how I have stripped out the PHI. I have the appointment date, time, PCC number, their reason, the full appointment note, who saw them, and hey, they owe us $25 for that forms fee. Let's go get it. There's their patient flags. And is there a care plan present? Yes. Note the notes column. You may add that to a report and say, why is that blank? That's by design. That's for that whole print, scribble, save business. So we have a blank column intended to be on the report if you'd like it present, so that you can print it, jot things down, highlight things, sign it, date it, scan it, save it, and prove to NCQA not only that you are huddling, but what you are huddling about.
Yes. Well, thank you, everyone.
Thank you so much.